My topic goes as cracking the code for treating pneumonia. Let's begin with a true case scenario happened in my hospital. A 44-year-old female was admitted with a 4-day history of fever, cough, and pleuritic chest pain. She has experienced increasing difficulty in breathing for the past 2 days. She is a diagnosed patient with type 2 diabetes for 4 years on metformin and sitagliptin. Examination revealed she was febrile. GCS was 13 out of 15 and oxygen saturation was 88% on room air. Her pulse was 112, hypotensive with the 90/60 blood pressure and tachypneic and bilateral mid and lower zone coarse crepitations on auscultation. Investigation revealed CBS 420 mg per deciliter. White cell shows neutrophil leukocytosis with normal hemoglobin and the platelet. CRP was raised to 411 mg per deciliter. Blood urea and the creatinine also raised, keeping in acute kidney injury with normal electrolytes and the liver transaminases. Her troponin was raised 1.15 nanogram per milliliter with ECG sinus tachycardia. ABG shows type 1 respiratory failure with metabolic acidosis with high lactate and PO2 FiO2 ratio with 67.7. So this is the chest X-ray of this patient. It shows a bilateral multilobular consolidation. So what are the possible differential diagnoses of pneumonia in this patient? Is it a community-acquired severe pneumonia? Is it an atypical pneumonia, especially Legionella? And is it a melioidosis? The answer would be it is severe community-acquired pneumonia. So what is severe community-acquired pneumonia? Okay. So this is the American Thoracic Society guideline published in 2019. According to this guideline, there are 2 major criteria and 9 minor criteria. To diagnose severe CAP, there should be 1 major criteria or 3 minor criteria. So our patient had a 1 major criteria and 6 minor criteria. So it is definitely severe community acquired. What is CURB 65? So it's a CURB 65 score can be used as a severity indicator. 1 point is allocated for each of the following: confusion in onset, urea more than 7 millimoles per liter, respiratory rate more than 30, blood pressure less than systolic 90 and less than diastolic less than 60, and age more than 65. CURB 65 equal or more than 1 need hospital admission. CURB 65 when it is 4 to 5 may need ICU care. When outpatient setting where urea is not available, you can use a CRB 65. So are you going to crack the code? Definitely yes. Why should you do it? A patient with uncontrolled diabetes in septic shock with severe CAP. It is essential to identify the specific type and cause of pneumonia to optimize treatment. How are you going to do it? Microbiology sampling in form of blood culture and the respiratory culture, urinary antigen for Legionella and the pneumococcal in certain occasions, and start broad spectrum empirical IV antibiotic. What would be the best choice for this patient? Is it a cefotaxime or ceftriaxone plus IV or oral clarithrol? Is it a piptas plus IV vanco or tico? Is it a meropenem plus IV vancomycin? Is it IV levo alone or IV cipro or gentamicin? So answer would be IV piptas plus IV vanco or tico or IV mero. You can use IV mero or imipenem plus IV vancomycin after discussing with the microbiologist. And we started piperacillin, tazobactam and IV tico because vanco was not available at that time. So this is our national guidelines. According to the guideline, the primary therapy for the severe pneumonia, cefotaxime or ceftriaxone plus oral or IV clarithrol, you can add vancomycin if you are suspecting MRS. In a severe case, especially risk factors for pseudomonas, cystic fibrosis, COPD, and the bronchiectasis, you can think about the piperacillin tazobactam and the meropenem, piperacillin tazobactam or meropenem or imipenem. And if you are suspecting MRSA, you can start teicoplanin or vancomycin. Levofloxacillin is a red line antibiotic. It's reserved category of antibiotic. You need a microbiology opinion before starting IV or oral antibiotic. So how are you going to escalate the antimicrobial therapy? Usually piptas with doxycycline is sufficient. If MRSA is suspect, you have to add IV vancomycin or oral or IV linezolid. Multifocal infections, especially in the multifocal infections. If melioidosis is suspected, escalate to IV meropenem. If preceding viral prodrome followed by a lobar pneumonia, think about post-influenza Staph aureus infection. There, you can start IV coamoxiclav or the ceftriaxone with added oseltamivir or Tamiflu. If there are high risk for HIV, think about PCP pneumonia. So what happened to this lady? She empirical IV antibiotic started after microbiology sampling, and noradrenaline started initially and transferred to the ICU, and patient was intubated and ventilatory setting adjusted to the maximum level, and inotrope support escalated, and we had to start 3 inotropes, and patient become anuric, and CRRT was started. And blood culture, streptococcal pneumonia identified with the 22 hours, fully sensitive to antibiotic. Sputum culture was no growth, and despite all measures, the patient passed away. So despite having a sensitive organism, patient succumbed due to the severity of the illness. Let's talk about another case. The case 2. 66-year-old female with a background history of ischemic heart disease, hypertension, and CKD was transferred from a local hospital with 3-day history of fever, cough, and shortness of breath. Examination on admission, GCS was 15 and mild temperature with saturation 92% on room air. Her respiratory rate was 24 and pulse was 100 and blood pressure 90/70. And her lung shows the bilateral basal capitation were found on auscultation. Investigation revealed CBS 162 milligram per deciliter with neutrophil leukocytosis. CRP was raised 281 and creatinine 177 with the raised blood urea, keeping with CKD1 with normal electrolytes. There were T inversions in ECG which are non-dynamic, and troponin was negative. So this is the chest X-ray of this patient. You can see the bilateral bibasal consolidation more on left side. And what would be your choice of empiric antibiotic? And what is the severity of this pneumonia, and what is the curve score? Curve score was 2 and it was a moderate cap. What is the best choice of antibiotic for this patient? Is it a IV coamoxiclav? Is it a IV coamoxiclav plus IV clarithrol? Is it a IV levo or IV piptas alone? So answer would be the IV coamoxiclav plus oral clarithromycin. This is the national guideline. When there is a moderate cap, you have to start IV coamoxiclav or cefuroxime plus oral clarithromycin. Alternative therapy would be the IV or oral levo. There you need a microbiology opinion. So, what happened to the patient? And the patient kept in the ward, and day 3 sputum culture grew streptococcal pneumonia, and fever settled after 48 hours and clinically improved. CRP down to 100 and white cell count dropped. And what would you do next? Continue IV ceftriaxone or clarithrol for 5 days? De-escalate the dose of same antibiotic or change to oral antibiotic? What do you think? Answer would be change to oral antibiotic. antibiotic. So how are you going to switch IV to oral and what is the duration? If patient is having severe cap on ceftriaxone and cefotaxime, better to start oral cefixime. If patient has a moderate cap and was on ceftriaxone or cefotaxime, you can change to oral coamexiclav. If the patient had a severe cap on was on meropenem or piptas, you can change to oral levo, and total duration would be 5 to 7 days. And with that, I would conclude my presentation. Thank you very much for your participation.